Dr. Yatin Mehta, who is Vice Chairman of Medanta and a consultant intensivist. He was the President of Indian Society of Critical Care Medicine. Dr. Yatin, please.
Good morning. First of all, let me thank the organizers, particularly Dr. Ravinder Mehta, for inviting me for your conference. I'm going to talk about what works in COVID therapeutically. As we know, the disease began from a province in China, Wuhan, and then it spread all over the world. And the first patients came to India in January, February. The central government sent us the patients from ITBP, and this is how we received. You can see how much of noise was made at that point of time. And these were the Italian patients whom we treated. Only one patient died out of 16. This was a paper which we published in IJMR in May 2020. This is where I work. I bring you greetings from Medanta, the Medicity, where I work. It's a tertiary care hospital. So those were the earlier days. There was very little evidence. And this was the first position statement by Indian Society of Critical Care. And as the year progressed, end of the year, a lot of recommendations and guidelines were modified according to as the more evidence came in. So these were the new current approaches guidelines, which were again published at end of the year, IJ, Indian Journal of Critical Care Medicine. This was one of our earlier papers where we realized pretty quickly that the neutrophil to lymphocyte ratio was a major determinant of progression of variant mutants, kappa and gamma and delta, which was the last wave in India, which struck us so hard. And now it is the Omicron, which the whole conversation is about Omicron. Omicron has more than 50 mutations, and out of which 32 are in the spike protein. Now, this is the protein which helps in attaching to the cell wall and attacks the human body. So based on the evidence which was there, NIH had this updated recommendations. And A was a strong recommendation, B was moderate, and C was optional. And based on the quality of evidence, which was very strong randomized large trials, opinion, and these were non-randomized observational studies. Quickly go through, what is the spectrum of the disease? Either you may be asymptomatic or pre-symptomatic infections, nothing probably needs to be done for that. Then you may have mild illness, little fever, little sore throat, diarrhea, nausea, and so on. And with the delta, you had loss of taste and smell. But there was no shortness of breath. Once shortness of breath appeared, then it becomes moderate illness, but the saturation of room air was still more than 94%. When it progresses to severe, then the respiratory rate increases to more than 30, and the saturations fall to less than 94, or PF ratio decreases to less than 300. And then when it progresses to critical illness, well, it advances to organ failure, respiratory failure, mechanical support to different organs, including AKI and CRRT, and so on. So these were the asymptomatic, where management is non-hospitalized patient. Mild and moderate also can be managed in non-hospitalized setup. You need to monitor the oxygenation, the respiratory rate, and so on. And when it progresses, then obviously you admit the patient, so it may be severe and critical illness. Post-exposure prophylaxis, well, for high-risk people, it is recommended. And normally, monoclonal antibody is what is recommended for these patients. So you can give bamlanivimab plus itazimab, which is not available in India, but you do get monoclonal antibody cocktail, casirivimab and imdevimab, 600 of each in one single shot. Either you can give sub-Q or you can give it an intravenous infusion, keep the patient for a couple of hours in the hospital, and then discharge him. Coming to the other progression of the disease, mild to moderate and not requiring oxygen, not hospitalized. Well, not hospitalized, not requiring supplemental oxygen, you can give monoclonal antibody, which may be casirivimab or plus imdevimab in India, or bamlanivimab plus iltazimab. And sotrovimab has just been approved by WHO. So these are all interchangeable. December 2021, because of the Omicron, the monoclonal antibodies may not be very effective against corona because these antibodies are directed against where remdesivir was given for 3 days in outpatient on outpatient basis, and the patients were significant improvement at 28 days compared to the placebo at 14 days and 28 days. So this is recommended now for 3 days. So the recommendation is if the patient is suspected to be Omicron, Paxlovid may be effective, but it is still not available in India. They were likely to be effective. It is included in WHO's recommendation of 800 milligram twice a day capsules for 5 days. It does include reduce the duration of the illness, and also the viral load goes down. But ICMR has recommended against it because of those teratogenic possibility. Coming to the hospitalized patients, quickly go through what I recommended, then I'll come to detail. Okay. So if the patient is hospitalized but does not require oxygen, do not give steroids. So recommendation is strong recommendation. You can consider monoclonal antibodies, but don't give convalescent plasma. All the evidence is against convalescent plasma. Patient is hospitalized and requires oxygen, then you can use remdesivir alone. If the patient's oxygen requirement is not much, or you can give remdesivir along with dexamethasone. Recommendation is 2B, or dexamethasone alone. Recommendations is B1. And you may, at some point of time, if the patient is getting worse, may use baricitinib or tocilizumab. I'll come to that. Which parameters to follow? There was no consensus on that. What evidence it was based on? Well, remdesivir, with the solidarity and discovery trials, there was no mortality benefit, but the illness duration and the severity was reduced. The ACT-1 trial, remdesivir was associated with improved time to recovery, 7 versus 9 days. Fewer patients in the remdesivir progressed to higher oxygen therapy or mechanical ventilation and so on. And there was a survival benefit. Post-hoc analysis, it was most evident when the symptoms were less than 10 days. And another study showed 5 versus 10 days, there was no difference. So its recommendation is 5 days. Then the concern came about why the patients were deteriorating the second week of the illness because of cytokine storm. This was a review article we wrote about the role of cytokine storm in COVID-19. So based on these, dexamethasone was added to the therapy. So you gave either remdesivir with dexamethasone. Theoretically, it may be advantageous because you reduce the viral load on one hand and then you give anti-inflammatory. Or recovery trial showed benefits of dexamethasone. So B1 recommendation of dexamethasone. Although one has to keep it in mind, steroids may theoretically reduce the viral clearance. Then if the patient's oxygen requirement is increasing, despite dexamethasone, one can consider tocilizumab, and baricitinib has just been approved by WHO. So depending on the case-to-case basis, if the inflammatory markers are going up, patient is critically getting worse. So what's the evidence for dexamethasone? Recovery trial, there was survival benefit in patients who required mechanical ventilation or high flow oxygen laser therapy. Then you may use remdesivir with dexamethasone. There are only observational some studies for that, and continuing remdesivir until 5 days are completed. When do you use this to a second immunomodulatory drug to dexamethasone? Well, you may use tocilizumab or baricitinib if the patient's oxygen requirement is going up or if the patient is getting worse clinically, or inflammatory markers are going up. There is no recommendation one drug over the other. Toci evidence was based on REMAP-CAP trial. It significantly reduced the in-hospital mortality. A number of patients with respiratory or cardiovascular organ support also was reduced. It was published in Lancet Respiratory Medicine. And in this study, we did not find significant, the primary endpoint was not met, but in post-hoc analysis, in the more severe patients, there was some benefit. Baricitinib was based on Cove barrier trial, It was a significant mortality benefit over standard of care therapy. Mortality also significantly reduced. AKI-2 trial improved time to recovery. So both these trials were positive, and that's why WHO has recommended that. Hospitalized requiring mechanical ventilation or ECMO, most use Sarlimumab, which has just been approved by WHO, or you can use tocilizumab. In India, when tocilizumab was not available, itolizumab also was used in many patients. Meta-analysis, 7 randomized trial, dexamethasone alone reduced significant mortality. Remap cap and recovery trial, mortality benefit, as I said, of dosing. ACT-1 trial was against, it was negative trial, so was solidarity trial. So if the patient has just been recently put on mechanical ventilation, you may add remdesivir also if it's within 10 days. Coming to oxygenation of these patients, the target saturation should be 92 to 96%, and generally more conservative approach is better than very liberal. You do not need to hit a target of 100 saturation. So this meta-analysis of 25 randomized trial, liberal therapy was associated with increase in hospital mortality, but these are non-COVID patients. Coming to the high flow nasal oxygenation, HFNC or HFNO, well, if the patient is in hypoxemic respiratory failure, then this should be tried first. NIV has minimal role as proven by these studies. So recommendation is if patient is hypoxemic respiratory failure, you give HFNC first. NIV only when HFNC is not available. Awake proning has become very popular during these times, and that is recommended if the patient's oxygenation is not good enough. But do not try to prolong your intubation initiation because of proning. So you can try proning initially, but if the patient is not getting better, you must go ahead with whatever you need to do. This was a meta trial group. Intubation at 28 days was lower in awake proning patients than in the standard care arm, although there was no difference in mortality in the two arms. But awake proning is being given, NIV as well as various oxygen therapies in COVID-19 patients, strongly recommended. When should you intubate these patients? Well, earlier, second wave, everyone was trying to delay because the mortality was so high in mechanically ventilated patients, but do not delay it too much. If any of these things are present, which are conventionally given indications for intubation, patient's sensorium is getting worse, his patient is remaining acidotic, despite different oxygen therapies, hypoxemia persists, then one can intubate the patient and ventilate the patient. How to ventilate this patient? Less than 30, higher PEEP is preferred, and you can use recruitment maneuvers also, and routine use of nitric oxide is not recommended, and conservative fluid strategy over liberal fluid strategy is recommended. So I'm not going to try to sell coal to Newcastle, addressing the nephrologist gathering about fluid therapy. I think you people understand and know it better than me. If the patient remains refractory hypoxemic, despite optimization of ventilation, that means after 16 hours of ventilation, recruitment maneuvers are not helping, and pulmonary vasodilators have limited role, then ECMO can be considered. So these were the early recommendations, beginning of 2020, which we recommended. Robert Bartlett, who invented ECMO, was the first author of this paper. So this was based on evidence there. But the mortality in ECMO also has remained high, particularly in the COVID times. So there is no insufficient evidence to recommend either for or against the use of ECMO in adults with COVID-19 and refractory hypoxemia, although this remains the only modality. If the patient is not oxygenating, what does one do? So unless there is a contraindication, one can use this, particularly if you're thinking in terms of lung transplant. But the mortality remains high, 37% in COVID times. Anticoagulation, well, if the patient is hospitalized and non-pregnant, requires low flow oxygen on the floor, then you may give therapeutic dose heparin. So this was based on the D-dimer levels. If they're high, you give therapeutic heparin dose, and one study has shown mortality benefit of that. Although low molecular weight heparin is preferred over oral anticoagulation, because oral anticoagulation is more of a role at domiciliary setup. For hospitalized non-patient adults who are in the ICU, you can give prophylactic dose heparin, A1, preferably low molecular weight heparin over conventional heparin. Therapeutic dose only if it is indicated. That means patient is a PE or is MI or thrombotic stroke, only then, not as a prophylaxis. And for hospitalized pregnant adults, prophylactic dose anticoagulation is recommended. This was based on 2 studies, RAPID trial and HEP-COVID trial. So in the ICU setting, these studies showed that therapeutic heparin did not reduce mortality, but may have a higher risk of bleeding events. Therefore, this approach is not recommended. But do not forget the basics of COVID-appropriate behavior, avoiding crowding, safe distancing, vaccination, and masking. So I thank you for your attention, and I'll be happy to address your queries at the end of the session. Thank you.
Thank you, Dr. Yatin Mehta. We will move on to the second lecture, Fluid Management in COVID-19. This will be delivered by Dr. John Prohl, who is an intensivist and part of the medical research group at BARTS. He also is honorary consultant physician in intensive care and nephrology at Royal London Hospital, BARTS Health NHS system. He has keen interest in AKI and has been part of more than 150 peer-reviewed publications and chapters. Dr. John Prohl, please.
Thank you very much for the kind introduction. It's a delight to be here. I hope everybody can see my slides. I've been tasked with talking to you a little bit about fluid management in COVID-19, and this is a very interesting area, and it's an area that's challenged us throughout the pandemic. There are a few disclosures that I'll just put up on the screen for form's sake, none directly relevant to the content of the presentation. So let's talk about COVID-19 disease. Really what we have here in hospitalized patients is a disease with hypoxic respiratory failure, high fever, systemic inflammation, and leading on to multi-organ failure with a significant instance of AKI complicating those patients. Fluids, both positive and negative on other organ systems, in particular the kidney. And this audience doesn't need to be reminded that acute kidney injury was a very important part of COVID-19. This is an early study from the United States, but it does give a good flavor of what was happening in the early pandemic. AKI complicated about half of patients in New York in this initial study. And you can see here the distribution of AKI in different environments, and really actually quite a lot of patients getting severe AKI and needing renal replacement therapy, particularly in the intensive care unit where 30% of patients with AKI were requiring renal replacement therapy. So clearly a major challenge, not just for the management of individual patients, but logistic in terms of the number of patients requiring extracorporeal support with perhaps limited resources, even in the United States. This is some data from my institution, where this is all COVID patients admitted to our hospital systems in the first wave of COVID-19 in early 2020. And about 1/4 developed acute kidney injury, so somewhat less than in New York. And of those who developed acute kidney injury, 16% or so required renal replacement therapy. Again, a little less, but the development of acute kidney injury is strongly associated with risk of death, and particularly more severe and persistent acute kidney injury. So a major problem in many different environments. But really, the problem we have in thinking about fluid therapy is not one that's unique to COVID-19. It's one we've been wrestling with for many years, and particularly in the context of sepsis. And we have this kind of rather existential conflict between the idea that we need to resuscitate the circulation and maintain organ perfusion and oxygen delivery and perfusion pressure, and the prevention of fluid overload. And this can sort of pull us in two different directions. And the question we really have is the balance between these two conflicting concepts different in COVID-19? And to what extent should we be treating our patients with COVID-19 like we're treating patients with ARDS in the context of sepsis related to more usually bacterial infection, as we saw it in our pre-COVID practice? I don't need to tell this audience the adverse effects of fluid overload on all the organ systems when it occurs, in particular the lungs, most pertinently here, but also in terms of gut function, and indeed the effect of fluid overload on the kidney itself, and therefore a kind of self-perpetuating situation where we've got impaired kidney function and homeostasis, and therefore impaired ability to resolve fluid overload. And this is a cartoon from a paper from a review from a few years back, sort of illustrating the ways in which fluid overload can oppose renal function by interstitial edema and increased venous pressure, all of which tend to oppose glomerular ultrafiltration. And really the process of renal recovery is coupled with a process of resolution of fluid overload. So clearly we want to avoid fluid overload, both for the kidneys and the lungs in our COVID-19 patients. But the question is to what extent these processes are happening in our patients and where we strike the balance and how this relates to our previous practice. It's very important also to appreciate that once fluid overload has occurred, it is difficult to resolve. Fluid is sequestered in the interstitium. You have disrupted extracellular matrix, which tends to become a sponge and retain fluid. You have impaired capillary function in terms of increased permeability, but most importantly, a degradation in the endothelial glycocalyx, which means that there is increased leakage into the interstitium. Refilling probably mainly reoccurs from lymphatics, but lymphatic return can be impaired in severe fluid overload. And when we try and remove fluid from the circulation, which may itself be relatively underfilled, and we exceed circulatory refilling from the extracellular space, then we risk our patient having recurrent episodes of hypovolemia, which may be adverse to the recovery of other organs, and may even trigger other adverse events like thrombosis, which has been observed in COVID-19. So a tricky dilemma to resolve fluid overload when it's occurred. So we should try and strive to avoid it as much as possible. But also we should not be overzealous in fluid removal in precarious clinical situations. So where do we go for a bit of evidence to guide us? Well, we're treating patients with ARDS and a beta viral cause, and so we went back to the evidence about management ARDS, and the highest quality study which sort of guided us is the FACT study, which was performed quite a long time ago now in 2006, and it bears reviewing what they did in the study rather than what we think they did in the study. So the FACT study compared two different fluid management strategies in patients with mechanically ventilated with established ARDS, one that was liberal, which meant to carry on with your standard practice in 2006, one of which was conservative, which was aiming to limit fluid overload and the accumulation of a positive fluid balance. There was no difference in terms of survival between these two strategies, but there was a faster liberation from mechanical ventilation in the conservative strategy, which was perceived as a benefit and led to widespread adoption of more conservative fluid management strategies in ARDS. This is the protocol that was used in the FACT study. It was a complicated study with a 2x2 factorial design with a pulmonary artery catheter. The most important thing to appreciate about this study is that the recommendations for fluid removal were heavily guided by the hemodynamic stability of the patient. And so patients needed to be effectively without vasopressors and with evidence of a reasonable cardiac output in order for them to have aggressive fluid removal. And patients who were more hemodynamically unstable were managed their conservative management of fluid overload was more conservative in the sense that they didn't prioritize fluid removal in this context, and this is sometimes not remembered, and but it was a key part of the study. The other key part of this study is actually what they achieved. The conservative fluid management group here, over time from enrollment in the study, basically they maintained an even fluid balance over time, a little bit of creep up and then crept back down again. The liberal group had progressive accumulation of a positive fluid balance. It's very important this group were not achieving a sustained negative fluid balance, which some people continue to sort of believe. It's also important to know that for full randomization, each group had a significant amount of fluid. They didn't try and take this fluid away again. That fluid remained in the equation. This was their initial resuscitation, which presumably the patients needed. A number of analyses were done of this study in terms of renal function. I've been a little bit critical of some of the metrics that were used here, but what I can certainly say is that the conservative fluid management approach did not result in more acute kidney injury, and by some measurements seemed to be relatively protective against kidney function and almost significant against need for renal replacement therapy. And so clearly this conservative approach is potentially good for the lungs and certainly not kicking the kidneys. Now we've got to temper this against evidence in other contexts. So this is a context of major abdominal surgery. These are patients who do not have ARDS. They have undergoing major surgery. They're euvolemic to begin with, and it was probing the evidence to suggest that fluid overload and positive fluid balances may be harmful in patients undergoing major surgery. And so they sought to maintain a essentially completely even fluid balance in patients undergoing major surgery versus a cautiously liberal approach, consistent with good practice in 2018, which was certainly significantly less keen on fluids than it had been a few years before. And so these were the two regimens, but really the point-active regimen was designed to provide a net zero fluid balance. The two groups were relatively similar, and except in the amount of fluid they received, which was clearly different. And there was no benefit in survival. And in fact, if you look at renal outcomes, although they were infrequent, there were worse renal outcomes in the more conservative fluid balance approach in terms of acute kidney injury and need for renal replacement therapy. So there clearly is a tipping point. If you're not fluid overloaded and you take somebody who's at risk of hemodynamic instability and you try and really be very, very sensitive on the fluid balance, you may worsen things for the kidneys and not benefit the patient overall. And so an important kind of caveat. And so really we've got to think for ourselves where we stand between these two different approaches, and if there's a compromise between perhaps the FACT approach and the relief approach, and where COVID-19 sits in terms of a disease compared to classical ARDS and a major surgery plan, both to operationalize the protocol and potentially to apply it slightly more safe fashion. And so what they did was they had a simpler protocol, which I'll put on the next slide, but basically it actually resulted in a slightly positive fluid balance rather than the even fluid balance in the FACT conservative arm, but much less positive than in the FACT liberal arm. There was less shock in patients treated with a flat light compared retrospectively to those in the conservative arm, the original FACT study. So this is potentially an easier to implement and slightly safer protocol, and sort of taking us back to out of the danger zone that may be indicated in the relief study, albeit in a different context. And here you can see the protocol is only if you are sure that the patient is reasonably hemodynamically stable. Again, an important caveat. So this brings us back to COVID-19 and our concept of resuscitation. So this is a graph about different stages in resuscitation, taken from an article, a meeting I participated in several years ago, for a volume deficit or a need for extra fluid due to reventilation, and then these optimization, stabilization stages, and eventually a DS. They need the rescue phase, and it may be that they need less resuscitation early on, or but certainly if they do, we will land on them in the ICU in the optimization phase. And what we're seeking to do is to try and limit further fluid accumulation. But obviously, the rapid de-escalation might be dangerous to other organ systems, particularly if we're trying to de-escalate a rescue phase that hasn't really ever occurred. Because then there is who might normally be within the ICU. Liberal strategy, but a conservative strategy to fluid management, but a pragmatic conservative strategy that was not aimed at sort of fluid removal, but aimed at maintenance of a fluid balance, and accepting the fact that these patients are likely to have relatively high and sensible losses and may actually have difficulties with fluid intake both before admission to hospital and indeed while they're on the wards. And aiming for a daily fluid balance that's even to slightly positive after we've given any initial resuscitation or volume correction for dehydration, which is often present at admission, and indeed a stable body weight during the first 7 days of illness, accepting the fact that patients are likely then to start losing flesh weight over time. And we provided some guidance to doing this in the ward environment, more perhaps to make people think about it than to strictly follow the guidance, but also really to think about exactly how much oral fluid these patients were getting. And often it actually was not very much when they were on, they were extremely breathless and on various forms of oxygen therapy. In the ICU, similarly, we had a protocol that was based around frac light. And again, it's a matter of thinking about what we're going to do and thinking about the need for fluid management, but not aggressively coming in and saying this patient has got a bilateral pulmonary infiltrate, so we must aim for a negative fluid balance. So I'll finish up by talking about sort of what's happened in COVID-19 over time, and we can reflect on the results. This is the results from the UK ICUs. You can say in the UK we've had 3 waves of COVID-19. The first wave, actually the worst of all, the second wave by far, and then the third wave, which has been a very large number of cases in the community, but a much, much more attenuated surge in the ICU. These are some statistics from our national audit, very comprehensive. So in the first wave, about 25% of patients required RRT, and notably, almost everybody requiring RRT has it in the context of mechanical ventilation and multi-organ failure. Okay, so we're talking about a complication of COVID-19 illness overall, not a single unilateral organ failure. In the second wave, we actually see quite a significantly lower proportion on renal replacement therapy, despite other characteristics being relatively similar, and that's fallen again in the third wave. The mortality of patients on RRT has remained relatively similar, perhaps actually increasing the second wave, maybe indicating some of the patients in the first wave who received RRT were actually perhaps didn't need RRT. And then there are obviously differences in the virus, and there are differences in the treatments and differences in the prevalence of vaccination in the population, although the majority of patients admitted to ICU in the third wave were of the small number of patients in the population who had declined or had, for other reasons, not been vaccinated. And so really this is the most interesting feature, this decrease in the amount of RRT, and that could reflect a number of things. It could reflect physicians being less keen to put people on RRT merely to manage fluid balance. It could reflect clinicians being actually dealing with fluid balance better earlier in the ICU. Significant for renal replacement therapy. This is probably again due to the reduction of severity of multi-organ failure. But of course, this is a beneficial effect on our overall population, and may also account for some of the changes in renal replacement therapy. So to conclude, our initial advice to run up to hospital in shock. They were pitching up to hospital with respiratory failure. They were spending several days on the ward, receiving oxygen therapy. They then got worse, got to ICU, got intubated. Then they were requiring vasopressors. Then they went into further multi-organ failure. And so they hadn't had a lot of upfront fluid loading. In fact, if anything, they had had a lot of upfront dehydration due to reduced intake and increased insensible losses. And so then taking these patients and trying to run them dry misinterpreting their clinical situation. And AKI, when it occurs, clearly multifactorial systemic inflammation, and actually difficulty in the context of systemic inflammation. And is it contraindicated if the patient's actually hypovolemic? We can. But improvement in renal outcomes is very difficult to interpret because we made so many different changes and improvements to our patient management. And I'll conclude there. Thank you.
Thank you, Dr. John. With that, we move on to the third lecture in this session, talking about preventing AKI in COVID patients. I have pleasure in introducing Dr. Marlies Osterman, who is a friend, and many of you would have seen her in all the AKI CRRT meetings in Hyderabad also. She is a consultant in critical care and nephrology at Guy's Hospital and King's College, London. She did her medical school from Germany, subsequently had postgraduate training in London and Canada. She is an active member of the...
Perfect. Yeah, I'd like to thank you and Professor Mehta for this very kind invitation to contribute to this important meeting. It's a great honor. It's also a challenge to follow the very eminent speakers who've given fantastic talks on COVID and AKI. My task is to follow and talk about prevention of acute kidney injury in patients with COVID-19. These are my disclosures, and they have not influenced this presentation. As John already alluded to, acute kidney injury was a major problem in the first wave. And in some countries, including, and in some institutions, including our own, it represented a severe challenge to the point that we almost ran out of capacity to look after patients with severe acute kidney injury. And here I have some front pages of newspapers highlighting the fact that institutions, including our own, were facing serious challenges at being at risk of not being able to treat all patients with severe acute kidney injury. So prevention of acute kidney injury is clearly relevant to talk about, and it was very important during all the waves we experienced in the UK. Now, before I talk about prevention, I'd just like to briefly remind people again of the pathophysiology and the risk factors for acute kidney injury, because I believe we have to keep them in mind if we want to prevent the development of acute kidney injury. And so to highlight those factors which we may be able to influence and other factors which we have no control over. This is the pathophysiology of COVID-19, as already demonstrated and presented by colleagues earlier. But essentially, COVID-19 is triggered by the virus binding to the ACE2 receptor. The virus then gets incorporated into the cells, and this leads to a cascade of various pathophysiological processes, which include a direct toxic effect on cells in the various organs. It includes hormonal disturbances. It includes the activation of inflammatory pathways and endothelial inflammation. And obviously, as we all know, the triggering of intravascular thrombosis, all combined with the release of inflammatory mediators. So numerous processes that ultimately lead to organ dysfunction in the different organs. And if we acknowledge that the ACE2 receptor plays an important role in the onset of COVID-19, then it's important to remember that the kidneys are amongst the organs with the highest density of ACE2 receptors. Now, we make use of this when we prescribe ACE2 blockers, ACE2 receptors inhibitors to people with renal disease. But in this case, the ACE2 receptor may contribute to the high risk of AKI. And within the kidneys, there are several areas where ACE2 receptors can be found. And again, this may explain why we see different histological and clinical features of AKI. So we have the nephron on the left side. In the middle, you have the glomerulus. And then on the right, I just showed a close-up of the glomerulus showing the podocytes, which keep the glomerular capillaries in shape. And it's known that ACE2 receptors can be found on all these different cells. So on podocytes, on glomerular capillaries, and also on tubular cells. And again, this may potentially contribute to the development of proteinuria in some patients and hematuria in others. And again, as shown here, when you compare the density of ACE2 receptors in the kidneys on your right with that of other organs, for instance, the lungs, then it's clear that the kidneys with a high density of ACE2 receptors are at very high risk of potential involvement in this viral infection. And we have some evidence, obviously, from post-mortem studies showing that patients who died with COVID-19 had evidence of viral infection. Here we have viral inclusion bodies in the peritubular arteries and also in the glomerular capillaries, all consistent with the histological features of thrombi within peritubular arteries and viral inclusion bodies on electron microscopy. So these are things which we have to keep in mind when we want to plan the prevention of acute kidney injury and prevention of renal involvement in patients with COVID-19. And obviously, not surprisingly, the histological features are extremely variable from tubular injury to collapsing glomerulopathy to sometimes as the benign histology, but RNA on genetic sequencing. And again, this autopsy report showed that viral inclusion bodies could also be found in those who may not even have immediate clinical features, i.e. a raised creatinine or proteinuria. So viral infection may potentially contribute to acute kidney injury, and we may not have immediate control over that. If viral infection occurs, microthrombi may form and block these peritubular arteries and glomerular capillaries. Again, this may be out of our control. And in addition, in patients with COVID-19, there may be a release of inflammatory mediators, and some patients may become quite inflamed, again, exposing the tubular cells to various pro and anti-inflammatory mediators. But on top of that, we also obviously are dealing with a heterogeneous group of patients, of whom some need mechanical ventilation, some may have cardiovascular problems, some may have a reduced cardiac output. John already alluded to the fact that fluid management may play a role. Some patients may be dry and others may get fluid overloaded. And patients may also need other medications with potential nephrotoxic side effects. So the risk of acute kidney injury is very large and includes many risk factors that can ultimately contribute to acute kidney injury. Here's a picture highlighting the complex relationship between mechanical ventilation and risk of acute kidney injury. And this alone can contribute to acute kidney injury and has to be kept in mind if we want to prevent acute kidney injury in patients with COVID-19. And similarly, as John alluded to, we know that hypovolemia and dehydration is harmful and can cause acute kidney injury. But we also now know that giving too much fluid and raising the CVP, raising the venous pressure can lead to renal congestion and again aggravate the development of kidney injury. So if you put this all together, then we have a picture like this, where in COVID-19, the kidneys are really at very high risk of failing. And many factors play a role, of which some are controllable and maybe even preventable, and some are completely out of our control. So what can we do? Well, this was a question when a very urgent AKI meeting was held in June 2020, at the time when a lot of institutions, including our own, had seen the peak of the first wave and had really experienced major challenges some institutions were overwhelmed with people with acute kidney injury. And again, the team of experts summarized the existing knowledge at the time. Now, obviously, we were dealing with an illness which at that time was 6 months old. It was a baby illness. It had only just started. We met in June, and all we had was the experience from experts across the world with a completely new disease. And we had data in the literature, sometimes conflicting, sometimes confirming. And what we knew at the time was, and I believe it's still the case, that acute kidney injury is usually multifactorial. And I showed you this graph earlier. And there are some factors that are directly related to the virus. There are others related indirectly to COVID-19, for instance, the fact that people need mechanical ventilation. And then we acknowledge that there may also be factors that are clinician-driven and potentially iatrogenic, for instance, fluid management, and John alluded to that. When we summarize the existing data, so this is 6 months data because that's how old the disease was at the time, and shared our experience, the conclusion was that acute kidney injury was really very similar to that of acute kidney injury in most critically ill patients. It was multifactorial, but it was possible that viral infection played a role and contributed, but there were so many other usual risk factors. And with that in mind, we felt that the prevention of acute kidney injury should really incorporate the usual steps which we normally do and undertake when looking after critically ill patients who are at risk of acute kidney injury. And therefore, it meant really individualizing the fluid management so that hypo and also hypervolemia was prevented, to optimize renal perfusion, and if necessary, to use hemodynamic monitoring, as the current KDIGO guideline recommends for non-COVID patients, and to keep an eye on kidney function, be mindful that acute kidney injury could occur. And then the second part of the recommendations really include usual recommendations copied and based on the current KDIGO recommendation. And as shown here, it includes the recommendation to avoid nephrotoxic drugs if possible, to acknowledge the risk of mechanical ventilation-induced renal effects, and to consider the kidneys when selecting ventilator strategies. We gradually learned that a high PEEP strategy was not always necessary and may be avoided in some patients. The team at the time also looked at specific drugs to prevent acute kidney injury. And obviously, the immediate drug to look at were antivirals, given this emerging evidence that kidneys may get infected in COVID-19, given the high density of ACE2 receptors. At that time, and I believe it's still the case, there was no evidence that any of the antivirals could prevent acute kidney injury. When we looked at the urgent report of the remdesivir trial published in the New England Journal, then the first thing to say is they obviously excluded patients who had severe kidney injury, either in the form of a GFR of less than 30 or being already on dialysis. But obviously, patients may have developed acute kidney injury later. In their outcomes, they reported acute kidney injury, and as you can see here, there is no statistically significant difference between the two groups. So when you look at remdesivir and the chances of preventing acute kidney injury, this study didn't show anything. Subsequently, the Solidarity trial was published, and this was a much larger trial commissioned by the WHO, and they looked at many different combinations and different antivirals, as shown here, also combined with either hydroxychloroquine or with interferon. And as you know, the Solidarity trial showed no effect of any of these drugs with regards to mortality, whether you looked at antivirals or hydroxychloroquine or interferon. There's no evidence that any of these antivirals changed mortality. I'm afraid the renal outcomes have still not been reported. So whether there was any evidence or not is unclear. I believe that if there had been an impact on kidney function, they would have probably reported it by now. But so far, we have no evidence that antivirals can change the risk of acute kidney injury. The next drugs of interest were immunomodulatory drugs, and we lumped them all together, steroids and IL-6 antagonists, together with immunoglobulins and calcineurin inhibitors. At that time, again, there was no convincing evidence that any of these drugs could prevent acute kidney injury. The recovery trial was subsequently published, and as previous speakers already said, they found a difference in need for renal replacement therapy, but they did not report the different stages of acute kidney injury. So although it had an impact on the use of renal replacement therapy, we do not at the moment know whether it reduced the development of AKI, different AKI stages. Other things which have been tested in the past are obviously anticoagulants. And again, at the moment, there's no evidence that either anticoagulations in the form of heparin or antiplatelet drugs can prevent acute kidney injury in patients with COVID-19 who did not have AKI at the time of admission. Similarly, there's currently no evidence that statins affect the risk of acute kidney injury. Now, ACE2 inhibitors and angiotensin receptor blockers are currently undergoing an investigation as part of the REMAP-CAP trial, and we will see whether the use of ACE2 inhibitors or ARBs increase or lower the risk of acute kidney injury. And I believe the data will come out certainly within the next 12 months. And non-steroidals as anti-inflammatory drugs, again, have been tested, but the effect on kidneys remains unknown. So this is where we were last in 2020. And really so far, no new drug has emerged or new strategy has emerged as a single strategy to prevent acute kidney injury. But as I already mentioned, in the UK for sure, acute kidney injury became a major problem and really hit us by surprise. And this led the NICE, which is the National Institute for Clinical Care and Excellence, to produce rapid guidelines. And they were focused on acute kidney injury and really prevention of acute kidney injury. And here we have a summary of this guideline, which was published in the BMJ. And this summary essentially highlights the key messages. Firstly, it reminds people that patients with AKI have a high risk, patients with COVID have a higher risk of AKI, and therefore reminds the clinicians to look out for it and to, if possible, always assess patients for acute kidney injury and treat it as early as possible and ideally, or recognize it as early as possible and ideally prevent it. They also urge people and clinicians to do some basic tests, and they include a urine dipstick to look for early signs of renal damage before creatinine may have risen. And this obviously is a very simple test, a urine dipstick looking for blood and protein, given the high prevalence of these findings. And then the guideline takes up a lot of, spends a lot of time reminding people of the importance of fluid status. And it summarizes what you've heard in the previous lecture. Again, a reminder that both hypovolemia and hypervolemia are harmful to kidney function. The best fluid status is euvolemia, and that the patients may need some fluids. If they do need fluids, there's no optimal choice at the moment. And patients who are fluid overloaded may need some diuretics, but diuretics should not be given to everybody. And this concept of keeping patients dry should be abandoned. At the same time, whilst NICE was producing a guideline in the UK, the Intensive Care Society, the British Renal Society, and the Renal Association got together. And again, it's really a sign of the urgency at the time. And they produced a clinical practice guideline with focus on critically ill patients who may need renal replacement therapy. And again, the key message here was to reduce the need for renal replacement therapy. The best measure and the most effective way is to prevent acute kidney injury altogether, because then you don't need renal replacement therapy ultimately. And therefore, this guideline, again, has a large section, which I've summarized here, to prevent acute kidney injury in critically ill patients. And the guideline published last year really highlight also in ill patients. They should use similar management strategies, but focus on fluid status and make sure that patients are neither dry nor overloaded. And there is also a long section, again, to remind clinicians of the importance of medicine reconciliation and optimization, and to avoid nephrotoxic drugs if at all possible. Finally, clearly there are new drugs in development. People are rapidly developing and testing new drugs. And these new drugs essentially look at the various different stages of the viral infection, which is displayed here. And there are obviously numerous steps which may be amenable to pharmacological intervention. And at the moment, drugs are being looked at to either target the ACE2 receptor or target the binding, or looking at the genetic subsequent protease development. And whether any of these new drugs ultimately will also prevent acute kidney injury in high-risk patients has to be seen. So in summary, together with the previous speakers, I hope we've convinced you that acute kidney injury is common. Patients are at high risk of acute kidney injury, but the pathogenesis involves many different factors. And to prevent acute kidney injury, it's difficult to address just one factor. There is no specific therapy for acute kidney injury, and there's no specific therapy to prevent acute kidney injury. And therefore, standards, recommendations, and standard strategies should be followed. And at the moment, we have no clear evidence that antivirals or anticoagulation or anti-inflammatory drugs work, but more data will emerge. And obviously, new drugs are in development. And with that, I would like to finish and again thank the organizers for inviting me. It's been a great honor.
Thank you, Marlies, for summarizing everything in the first session. So, any questions, can you please put them in the chat box? Meanwhile, I will request Dr. Mehta for his comments on this particular session.
First of all, Yatin, John, and Marlies, thank you for a wonderful, the knowledge that has emerged with respect to the waves of the pandemic, and the evidence to date showing that AKI frequency has reduced and RRT requirement has reduced, which all seems to be related to the modulation of the different Delta versus Omicron versus the previous elements. I think the question is, do you think that our therapeutic strategies have also influenced outside of these changes in the virus, have our therapeutic, so in other words, I'm trying to ask is it the process of care versus the actual disease pathogenetic mechanism which has influenced what we are seeing now? And how do you put that in context for what is it in the process of care which has evolved to give us the better outcomes?
We can start with Dr. Yatin Mehta, then go on to John, and then Marlies.
Okay, Dr. Mehta. See, I think there are two aspects of it. One is the virulence or the severity of the disease which the Omicron produces versus the Delta. And it is a given that the Omicron variant is much more transmissible but less virulent disease. So it basically lesser number of people get sick, lesser number of people get admitted to the hospital, lesser number of people get on the ventilator,
and lesser number of, as you could see from the statistics, require AKI. That is one aspect of it. Second aspect of the thing is that maybe a fluid management has improved. We have learned over the last year and a half, because we really didn't know what to do in the beginning. When new disease had struck us, and how to manage the fluids and how to manage the RRT if required, and we didn't really know that. So probably we were too conservative regarding fluid management and following strictly the ARDS network restricted conservative therapy motto. But over a period of time, we have learned it that probably eubulimia, as Dr. Osterman rightly pointed it out, may be a better strategy than either liberal or too conservative fluid management. The drugs have virtually remained the same. Many of them have been thrown out. So there is really nothing very significant about the management, the pharmacological management of COVID-19, which is nephrotoxic or which is not nephrotoxic or which has affected the AKI. But as you can see, maybe overall management has improved, and that's why the incidence has gone down to around 19%.
Thank you. John?
Yeah, I mean, I would agree with that. I think I've got Omicron COVID right now. I don't have acute kidney injury. I'm just sort of tied up at home with the kids. But it's so clearly the disease has changed, but the susceptibility of the population has changed. But what we're doing in the ICU has also changed. And in the beginning, we were kind of terrified. We were thinking that these were going to be people who were able it. We would had 10 patients who were sicker with it in their chest than we might have had in 6 months beforehand. And we were, we sort of were trying to do things to improve the outcomes. And that's often results in, and the same thing as Marley said with the high PEEP strategies, a lot of recruitment. And we found in the end, by bitter experience, that actually a gentler approach was better. And I think that's a good principle to take in any time when you have an uncertain situation. First, do no harm. And we actually were trying to improve outcomes. And in fact, I think as well with the fluid management strategy, what we didn't do is actually go and read what ARDSNet had said. We just applied what we thought ARDSNet had said. And ARDSNet didn't say take people dreadfully negative. They said maintain an even fluid balance to prevent things from getting worse. And that's really what we should have been doing. And it was, and to some extent, we've been too successful at preaching about fluid overload in other circumstances. But I do think, however, there is some evidence that immunomodulatory therapy has had an effect on kidney outcomes. And I do think that in the ICU, use of steroids and use of tocilizumab have improved renal outcomes as they've improved global outcomes overall. And so that's also had, but that's also telling us something else. It's telling us this is an inflammatory disease, an inflammatory process. And if we can arrest that process, we can also arrest processes that lead us into getting worse fluid overload by making the patients in a greater state of shock and with greater capillary permeability. So it's very complex. And it's a bit like these sort of sports teams. They make 1,000 incremental gains in order to win the gold medal. And that's what we've done, rather than having one individual thing you can really hang your hat on.
Thank you, John. Marlies.
Yeah, no, I would agree with what has already been said. I believe it's a multi-step success, I think. We have just looked at the AKI development and incidence in the 2 waves. And as I said, in the first wave, we were completely overwhelmed, where we had in our own institution an AKI incidence of 75%. And ran out of dialysis machines. And in the second wave, our incidence was less than 50%. And the analysis so far, if you compare them, is that patients in the second wave there was a statistically significantly much higher use of all the anti-inflammatories, and that's clearly significant. So steroids, IL-6 antagonists, and also less mechanical ventilation. So we're just trying to find out now whether it's the anti-inflammatories themselves that may have prevented AKI, so having a direct effect on the kidneys, or whether they had an indirect effect just by keeping patients making them less inflamed and getting the inflammation under control. Maybe as a result of this, the kidneys also benefited indirectly. We're trying to sort that out, but it's there's undoubtedly a change in clinical practice, or there was a change in clinical practice through the pandemic.
So this is thank you for bringing that point out. I just want to put one more question to all three of you. In the morning today, both on the pathophysiology, one of the elements that just come out for acute kidney in general and particularly for COVID-19 is the thought process that mitochondrial dysfunction is a common pathway. And in that setting, then treating it with, treating the NAD aspect of things, could nicotinamide be a option? And in fact, there are some studies from both Dr. Samir Parekh published in Kidney 360 and some other recent ones. So what do you all think? Have you
failure and actually interventions that can prevent things upstream, like the anti-inflammatories, may be much more effective than something that's very much downstream. But, if you've got your patient on ECMO in multi-organ failure, then, that's kind of situation where you might be trying to improve outcomes. But we certainly haven't been using nicotinamide specifically.
No, I haven't used it. I really have no experience of using nicotinamide. Used loads and loads of vitamin C in the previous wave, but that also we have given up now.
Okay.
I have no experience either. No, we haven't used it. Sounds very exciting. But...
Yeah, I mean, I do think it's interesting, Ravi, because we've got to be. There's been some very controversial, and a lot of people who we know very well who've got quite a degree of fame in the intensive care world have espoused various treatments based on a degree of observational evidence and some very plausible scientific rationales that haven't necessarily been sustained in other people's experience. And it's become, I mean, one of the saddest things about the pandemic has been that there's been this sort of division, and people who we could at least have a debate with gone out onto one sort of extreme. And so I think when we come, on the flip side of that, the real, I think, success of the pandemic has been the conduct of these large multi-center randomized control studies that have brought certain things into the frame, like steroids, which, and tocilizumab. I was a great skeptic about tocilizumab. I thought it would have far more adverse effects than it would have benefits. But I was converted, and you would never have converted me without a randomized control study. And so that's what we need. And I do think we should just be therapeutic enthusiasm has really been a socio-political problem during COVID-19, which has been very difficult to deal with. And I think it's caused a lot of harm to the public and things like that, particularly in places like in India and other places around the world.
Thank you, John. Thank you. Back to you, Raj.
Yeah, with that, we will break for tea and reconvene in exactly 15 minutes. 6:30, we will start the last session. Thank you. Thank you, Marlis. Thank you, Tim. Thank you, John.